Welcome everybody to yet another teaching grand rounds brought to you from our SJMC Cardiology team. This is the 10th grand rounds for the 5th of June 2021. Okay, and we have an exciting session with the usual case presentation and discussions, and it will be chaired by my colleague, Dr. Navin, and the rest of the team here, Dr. Kanan, Dr. Shamrus, and Dr. Yap will be participating. Okay, now before we begin, I would like to run through some housekeeping. Just to remind you, we will be using interactive questions and answer using Slido. So I hope you're watching this on a large screen device like a tablet or a PC. Then ideally you use your mobile phone to ask your questions. And then later on you use your mobile phone to scan for CPD points using the MMA app. So you can go to slido.com and the code is 546085 and join us there for any Q&A. Okay, there will be some MCQs. Can I borrow your mask? There will be some MCQs, and there will be 3 MCQs. And if you put your proper name down, I'm pleased to tell you that there will be a prize for the winner. Okay, there will be a special prize, a special edition or something we'll show you later. Okay, so stay tuned. All right, so there will be a special prize. Okay, now before I hand on to the chairman, I will just want to get you all going with Slido. So just to know who's viewing, so just to test out whether you guys are on Slido. Sorry, who's viewing? So can you please go to Slido, and now it will show the poll. And can you tell us who you are, whether you're a specialist, a GP, or other? Let's see if it's working. Can you please test for us? Anyone on Slido? Okay, we've got a few answers there now. 3/4 GP so far, specialists. Okay. Thank you for checking in on Slido. At least we know you guys are watching and paying attention. The echo. Okay, all right. So I will switch over now to our chairman, Dr. Navin, who slides. Okay, so over to you, Dr. Navin.
Hi, very good afternoon, everyone. I hope everyone is staying safe and well out there. Thank you for joining us today for our 10th Cardiology Grand Round with the odd title of "But Doctor, I Don't Have Chest Pain." So you must be thinking, why did I come up with this title? So because the thing is, we've always been sharing cases of patients who present with chest pain, causes of chest pain, etc. So this time around, there's a twist to it. We're going to share some cases of patients who presented with atypical symptoms. Right, and joining me today is our handsome and esteemed panelists. We have Dr. Kanan, Dr. Shamrus, and Dr. Yap.
Hang on a second now.
Yeah. Okay. Right. Okay. So I'm sure a lot of you will know this character, Dr. House, a fictional TV character who comes up with the most unorthodox diagnosis with his out-of-the-box methods and thinking. And I'm not sure many of you know, but this show was partly actually inspired by another fictional character, the great detective Sherlock Holmes, right? But be rest assured, the cases that we are sharing today are far from fictional, and it's some of the real cases that we've actually come across in our line of work. And hopefully all of us will be able to benefit from this discussion today. Okay, so no doubt chest pain is a very typical presentation to emergency department, right? And I'm just going to go through this quickly, right? Because that's not what we're going to concentrate on today. So these are the usual questions that we ask, part of our history taking. And the differential diagnosis It can vary from multiple causes, from cardiovascular causes, pulmonary causes, gastrointestinal, musculoskeletal, or neurologic causes, right? So those are the usual things. It's a busy slide, but I'm just going to go through this quickly, right? And these are the life-threatening causes of chest pain. The things that, if you don't pick up early, it's going to be detrimental to the patient. And this includes acute coronary syndromes, pulmonary embolism, tension pneumothorax, aortic dissection, esophageal rupture, pericarditis with tamponade, not commonly seen, the final one, but the first few are actually something that we see on a daily basis, right? Okay, but do all patients present like this? If only life was that easy, especially for us doctors, right? So instead of thinking within the box or even outside the box, like what Deepak Chopra said, just get rid of the box, right? And then we'll start to see all the subtle signs and symptoms and pick up patients who present with atypical symptoms. Okay, without further ado, I'll go to the first case. So this patient was a 42-year-old Malay man with no known medical illness such as diabetes or hypertension. Chronic smoker, 20 pack years. He basically came to emergency department in the evening complaining of one episode of diarrhea, and he had about 3 to 4 episodes of vomiting for the past 2 days, and also a new onset epigastric pain and a bit of giddiness. Right, so that's the vitals on presentation. He was hypotensive on presentation. The BP was about 90/60, and he was actually given fluids in emergency, total of about 4 pints, but he remained hypotensive. The systolic remained below 100. His heart rate was about 68 beats per minute. He was afebrile. Lungs were clear. CVS, no murmurs heard. And the abdomen, there was mild tenderness at the epigastric area, but no guarding. Okay, so we're going to go to the first Slido question. Just based on the history and physical examination, I would like the audience to vote what they think is the differential diagnosis. And this is going to be the first of 3 questions. And at the end of the session, we will actually reveal the answers and the results. Dr. Allen?
Yes, switching now.
So
hang
probably
on.
Okay,
sorry. I'm going to stop. Okay.
Okay, can you guys see this slide? So what is your differential diagnosis? Please enter your answers now.
We'll give about 30-40 seconds. Let's get some responses. Don't forget there's a prize. Okay. There's a prize for the top winner. All 3 who get all 3 right, and the fastest time.
Fastest, yeah.
Looks like number 2 is leading. Number 2 is leading.
Okay, interesting.
5 responses. Can we have at least 5 more?
We have to give them a bit more time.
Yeah. So get onto Slido at 546085, and then the poll is there right now. Okay, so please choose your answer.
Number 2. Acute gastroenteritis with hypovolemic shock.
I would have put that down as well. I mean, all the answers are fair. Yeah. I mean, they're not totally wrong, I think.
Exactly.
Yeah.
So that's why we'll go through the discussion and.
Okay, we got 11 responses. 1 or 2 more, maybe. Make it 12. Make it 12.
15 is possible.
Yeah, 15 is possible. Come on, guys. Let's have small responses. Wake up. Yeah.
I think 15 no price.
Cannot fall asleep. Yeah.
Price not effective enough.
We didn't say what the price. That is a special edition of something from SJMC.
All right.
Special price. Yeah. We're stuck at 11. Oh no, 12. Yeah. Gastroenteritis is still leading.
Okay. Interesting.
Oh no, tying now with coronary event. Okay.
Because cardiac center.
That's the clue.
2 more. Can we have 2 more responses? Thank you. Yeah. 14. I think we
Close the
can close, but I'll leave the poll open so you guys can still continue to take it. I just switch the presentation back to Dr. Navin.
All right. Okay. So now this is the first question to panelists, and I'm going to get Dr. Kannan to help us answer it. So Dr. Kannan, what is your comment on the clinical presentation of this patient, just based on the history and the physical examination? What are your thoughts?
Thank you, Navin. I think this history has all the features of acute gastroenteritis. The patient is also hypotensive. His pulse rate is about in the high 60s. The abdominal examination is virtually unremarkable, except for mild epigastric tenderness. So I suppose volume loss could explain the hypotension, except that the degree of volume loss based on the history doesn't seem to be excessive. One episode of diarrhea and 3 or 4 episodes of vomiting.
And that's over 2 days.
So volume loss doesn't seem to be that much. And it's also surprising that the blood pressure did not respond to the large volumes of fluid given during resuscitation. Septicemia could explain the hypotension, but there is no fever. Acute pancreatitis, I think, certainly is a consideration, but needs to be ruled out. But there are very few signs to support this. Mild epigastric tenderness, nothing more than that. So the odd finding is the relative bradycardia. I remember that typhoid as a gastrointestinal disease can cause bradycardia, but there are no other features to support the diagnosis. There's no fever. And history, I think, is also rather short. So the relative bradycardia will keep me thinking as I look out for the investigation.
Yeah, correct. So I think the clue there is the fact that, despite having a BP of 90 over 60, he was never tachycardic. And his heart rate remained actually in the region of around 60 to 80 at the most. Okay, so I will share some blood test results. So his hemoglobin was normal. White cell count was about 11,000. Platelet was normal as well. So of course they actually checked for dengue and cirrhosis and serum amylase, because these were things they were thinking of: dengue, leptospirosis, pancreatitis. But all of it was actually within normal limits. So now below I have the cardiac enzymes. So you must be thinking, why did they do the cardiac enzymes? Because, like I mentioned, one of the diagnoses that they were thinking of was actually leptospirosis. So, in a patient with leptospirosis, you would expect actually myositis, CK elevation. So that's the reason that they did. And if you can notice that the CK was actually about 6 times the upper limit of normal. And the CK-MB, which is quite specific for the heart, is also elevated, right? Grossly elevated, yeah. And now I'll show the ECGs. We'll come back to the discussion later, right? This was the ECG on admission around 4 p.m. And another ECG was done at 8 p.m. I'll explain why later. Why was there a repeat in the ECG, right? So maybe if you guys want to have a closer look, I'll just leave this slide on for about maybe 10-20 seconds. Right, so that's the first ECG. Second ECG. All right, so Dr. Kannan, now that you've actually seen the blood test and also the ECG, what is your thoughts now? What is the thoughts on the possible diagnosis, and what further tests can you do to confirm the diagnosis?
I don't think the ECGs support any definite acute cardiac event. The only thing I can say is that the second ECG, the R wave in 3 has lost its amplitude, but I can't say more than that. I would have probably just passed the ECG. But the cardiac enzymes are definitely very elevated. So, you can have a normal ECG. If you have an acute cardiac event involving the circumflex territory, your ECG can be quite silent. So at this point in time, an acute coronary syndrome certainly has to be considered. And I think it's time for me to do a bedside echocardiogram for this patient.
All right, okay. So your further test would be a bedside echocardiogram, right? Okay, so this is the echo that was done, right? We have a short axis here and a 2-chamber view here. So Dr. Kannan, what are your thoughts on the echo? I've actually put up a arrow there to help the audience actually see it a little more clearly.
So this is a short axis view of the echo. At about the 7 o'clock position is where the inferior surface of the heart subserved by the right coronary artery is. At about 11 to about 3 o'clock position, you have the anterior surface of the heart subserved by the left anterior descending artery. And from about probably 3 o'clock to about 6 o'clock, you have the lateral surface of the heart subserved by the circumflex artery. And as you can see on the first slide, if Navin will show that again, obviously the inferior surface is not contracting as well as the rest of the cardiac chamber. So from this, one would think that there is a event in the inferior surface of the heart, inferior myocardial infarction in progress. 90% of the time, this is probably related to the right coronary artery. 10% of the time, it may be related to a very dominant circumflex artery, in which case you would expect the lateral surface to also give rise to trouble. So we would call this regional wall motion abnormality. Having seen this and putting it together with the cardiac enzymes, we would say that an acute myocardial infarction involving the inferior surface of the heart is in progress. To explain the symptoms.
Correct. Yeah. So you see the relative hypokinesia in that region. You can also see it in the two-chamber view, right, at the basal inferior aspect. Yeah, so that area, right? So of course the ECG is, me and Dr. Kannan were looking at these ECGs, and I was telling him there's some abnormality there. He was like, Navin, I'll pass this off as normal. I said, yeah, it's very subtle, and most of the panelists also agreed that, nothing really significant there. But when I first saw this patient in the ECG, but of course by putting all the pieces together, then it seemed to make sense. I thought there was slight ST elevation in lead 3, very minimal, right? And then the subsequent ECGs just showed that a bit of T inversion in that same region, right? So, but not the best of ECGs. Okay, so, yeah, so what happened next? The patient was referred to the cardiologist about 4 hours after the patient was, treated initially in the emergency department. The ECG and the blood test was reviewed, and a bedside echo was done, and the diagnosis made was actually inferior myocardial infarction in cardiogenic shock. Why? Because, like what I mentioned, the patient was hypotensive despite fluid resuscitation. And by 9 p.m., the patient was pushed in for an angiogram, and by then he was already on a single inotrope. Okay, so I'm going to share the angiogram images, right? So this is the left coronary system. You can't really see the circumflex very well in this view, but this is the left anterior descending. And for a person who is not a diabetic, it does appear to be quite small. The vessels are quite small and a bit of a diffuse disease, if you can see this area, some irregularities there. But interestingly, you can actually see a faint retrograde here, right? And this is actually flowing in direction to the right coronary artery, right? So you can also see here, there's very faint collaterals going from the septals of the left anterior descending artery. And when I took a shot of the right coronary artery, it was totally occluded, right? You can see here, there is no flow distal to this segment, right? And even these areas, there are some narrowing. So that was wired down, ballooned, a stent was placed, and this was the results after that. The flow was actually established. So this patient definitely had an acute coronary event, but he presented with very atypical symptoms, more of acute gastroenteritis. And so that's why there was actually a delay in managing this patient. But what helped was actually, by looking in detail to the clinical presentation, the fact that it was hypotensive, but never tachycardic. The cardiac enzymes, of course, helped. The bedside echo as well, right? ECG probably not the best, like I mentioned. So, yeah, that's another view. You can see actually, before this, the vessel was totally occluded from this segment. And so the patient did well. Post angiogram, he was actually off the inotropes. And you can see the trend of the cardiac enzymes. So it peaked at day 2, and subsequently it came down very nicely. And as part of his screening, we of course checked his cholesterol levels. Not too bad, total cholesterol of 5, LDL of 3.5, fasting blood sugar was normal, HbA1c was normal. So most likely his only risk factor was the fact that he was a relatively heavy smoker, right? No family history as well. Anything that anyone wants to add? Any comments from the panelists?
I just wanted to ask, because this atypical presentation, where the clinical findings or symptoms initially are very much like gastroenteritis, and if I saw this patient, I maybe would not have sent the cardiac enzymes.
Yeah.
You know, and if the cardiac enzymes weren't positive to start with, this patient probably would not have been referred to a cardiologist at all, because the ECG was quite normal and there were no other clues.
I mean, you were lucky in the sense that they were thinking of leptospirosis, so they decided to send the creatine kinase levels. Yeah.
So it makes us think, you know, this is quite a lucky sort of finding, and that someone decided to do a cardiac enzyme, which is very unusual, isn't it?
Yeah.
For a young patient with abdominal symptoms.
Correct.
So the only clue really is someone has to spot the heart rate.
Yeah.
When Navin showed this case to me, I missed the heart rate completely. I was just looking at acute gastroenteritis until he pointed out the heart rate. So I think if you go back to your history and your examination, there are little clues that causes you to think that maybe we have to think about something else.
And the other thing you need to think about, why is he in shock? I mean, why was he in shock? I mean, you said yourself that the diarrhea wasn't very, significant.
Yeah.
Why was he hypotensive? So as part of the investigation for any shock, you would hope that someone would order an echo and, hopefully pick these things up, even if they didn't send any cardiac markers.
Yeah, true. That's another bedside test that can be done even at the emergency level by the medical officer. Sometimes it's done here. An echo test that would have been useful. All right. So the take-home lesson from the first case is basically to remember that in patients presenting with acute gastrointestinal symptoms, always consider cardiac causes. We do see a lot of patients who, actually present with, especially inferior MI, just coming in with epigastric pain, nausea, vomiting, right? And in this case, the only clue was the hypotension with the relative bradycardia, I would say. All right, so we'll move on to the second case. Second case is a 53-year-old gentleman, denies any prior medical illness, came in with very vague chest discomfort since 6 a.m. And his main complaint was actually the pain radiates to both his earlobes. No shortness of breath. He was a non-smoker, works as a manager, no significant family history. Blood pressure was about 120/80, pulse rate 100, borderline tachycardia. All his peripheral pulses were palpable, no obvious radial inequality or radiofemoral delay. Heart sounds were normal, no aortic regurg murmur, and his JVP was not raised. Okay, so this is for Dato' Yap. Sorry, no, this is, Dato' Yap. So what is the differential diagnosis based on the history and physical examination? I know I've not given much. So just the history and the physical examination. What are your thoughts, Dato' Yap?
Yeah, so if we can stay on this slide for just to go through the history again. It's a short presentation of chest pain, and when I see a patient with chest pain, the differential is very wide. So we got to look for some clues to see what are the possible causes in this case. So, he's in his 50s. Although he's a non-smoker, I think the first thing I would think of with chest pain is acute coronary syndrome. But acute coronary syndrome with chest discomfort may radiate to the jaw, may radiate to the arm. So maybe, I don't know if this patient says he's getting jaw ache and thinks it's very close to the ear, could be, but he doesn't have shortness of breath. So the other things that I would think about, could it be infection? So I'll be looking for any sign of fever or cough. Especially, this year, everything is COVID until proven otherwise. Then we got to think about other causes relating to the lung. Could it be a pneumothorax that can cause acute chest pain? could it be a pulmonary embolus, which also could cause acute chest pain? But in this case, there's no breathlessness, maybe less likely. And then possibly related to the heart aortic dissection, especially if there's atypical pain with tearing pain or radiation to the arms or the ears or the neck. And I think lastly, I would also include upper GI causes into a cause of chest pain, because we often do see patients having pain that radiates outwards. They've got a burning up towards their neck, their throat. So these are all possible causes, and I think at this point in time we got a history, but I will be looking for more clues with some basic tests such as ECG, X-ray, and maybe some blood tests.
All right. Okay. So let me give you the ECG of the patient, right? So we'll discuss on this ECG in a little while, right? So again, I'll let the audience have a look at the ECG. Okay. So what are your comments on the ECG, Dr. Yap?
Okay, so if we stay on this ECG for a little while, when I first look at this, I noticed that the patient is slightly tachycardic. The heart rate is probably about 100, and that could just be a sign of something non-specific, like if they have an infection. But in a tachycardic ECG, I would look for whether the rhythm is regular. So first of all, is this AF or is this a sinus rhythm? And in this ECG, I see that there are clearly P waves. The rhythm, the QRS is regular. So this is a regular sinus rhythm with tachycardia. Then if we look at the P waves, they all look okay. The QRS complexes, they are narrow, so they're not widened, but there is a slight hint of big QRS, although this technically does not fit the criteria of LVH. So we are looking at a total of squares in the V1 and V5, V6 to be more than 7. But these complexes are quite large, and they are approaching the size consistent with LVH. Additionally, if you look at the V3, V4, V5, and V6 T waves, they are inverted when compared to V1 and V2, where the T waves are upright. So in these positions, especially lateral positions, to get inverted T waves would be suggestive of left ventricular hypertrophy. So in summary, I think this ECG shows sinus tachycardia with some signs of LVH.
Okay. So as you mentioned, the ECG is suggestive of actually LVH with a strain pattern. But if you look at the presentation, right, Dr. Yap, his blood pressure was actually normal, and he denies any prior medical illness. So what can be the possible explanation for that? That although the ECG shows LVH, the patient is actually normotensive, he denies being hypertensive.
Yeah, so we do have a lot of patients with variable presentations and variable histories, and at a guess, if you see someone with possible LVH, they may certainly have been having hypertension in the past. Either they did not get it diagnosed, and in fact, this patient's blood pressure might be high normally, but there's something acute. Let's say if you have an acute infection or acute coronary syndrome, this may lower your blood pressure to a lower level so that it appears to be normal.
Right. So you could have been relatively actually hypotensive on presentation.
Yes.
Okay, so Dr. Shamrose, what will be the next investigation that you would like to carry out on this patient?
Well, let's get another basic test out of the way. I mean, did you do any chest X-ray?
Yes, I do have the chest X-ray here, and would you like to comment on this X-ray?
Okay, it's an AP X-ray film, but the mediastinum appeared to be enlarged to me, but it's not
area, right?
Yeah, that area looks a bit enlarged to me.
Yeah, a bit suspicious.
Yeah, but in an AP film, you just have to take it in context, okay?
And having seen that X-ray, what bedside test you think would have helped?
I mean, in someone like him with chest pain, there's no significant ECG changes, but there's a suspicion that he might be hypertensive before X-ray with widened mediastinum. I would definitely want to get an echo, bedside echo. to make sure I'm not missing anything. You know, it will tell me a few diagnoses, whether there's anything in relation to any cardiac events, or, you know, definitely I want to see the aortic root to see for any flaps or anything like that. At this point, I'm already thinking about something atypical. I want to be sure that I'm not missing anything catastrophic. Yeah.
Sure. So an echo was done, and I will share the images here. And so as you can see, that's the aortic valve there, right? So usually it has 3 cusps, which you can see, right? But there's something a little odd there. There's another line that you see that you usually don't see. Otherwise, we just call this the Mercedes-Benz sign, right? So that's actually a dissection flap. Won't you agree, Dr. Shamros?
Yeah, definitely. I mean, the first thing in the parasternal long axis, I mean, the right side of the screen, you can see the aortic root is enlarged, dilated. So that gives you the first hint. And then you can actually see a flap there. So this is definitely, you know, ascending aortic dissection.
So this is the left atrium, and this is the aortic outlet. And you can see usually the size is like in relation is about 1:1, the ratio, but here it's definitely dilated. And you can actually see that dissection flap there very clearly, right? Okay, and yeah.
Can you show the pericardial effusion?
Yeah, there's a bit of pericardial effusion as well there, right? That might not be a very good sign. Could be a sign of impending tamponade.
So Naveen, I mean, looking at this now with the relatively normotensive blood pressure earlier, would you be more worried now?
Yeah, I'll be more worried. You know, the fact that it's probably a hematoma form somewhere is leaking into that, and that's why it's normotensive, right?
Yeah.
And Dr. Shambus, what imaging tests would help to establish the diagnosis in this case?
I mean, the next test usually would be a CT, multi-slice CT to confirm the diagnosis. I think that's CT of the aorta, CT aortogram. Yeah.
Okay. So that was done for this patient, and I'll share okay, the first one, the run is a little fast. There'll be another run after this. All right. Okay, so you can see that's the aortic root, the ascending aorta, and you can actually appreciate the flap there, right? And this is the arch, going up the arch, right? You can still see the dissection flap there, and now we're going down to the descending aorta. Again, you can see the flap extends all the way down, right? So this patient did present with actually an aortic dissection. And if that was not so clear, I also have some still images, right? The red arrow is actually pointing towards the dissection flap, right here in the ascending aorta. And here you can actually see the descending aorta. So one of it is actually the true lumen, and the other one is probably the false lumen. Okay. All right, so Dr. Shamros, if you were to see this patient who presents with chest pain, you know, would you think that an angiogram will be beneficial or detrimental? Instead of doing some, you know, just in case no imaging was done and the patient was pushed straight for an angiogram.
I mean, I pray those kind of things don't happen anymore in the current era. I mean, but people have done coronary angiogram for acute aortic dissection in the past, if you believe it or not. I mean, most of the time you can actually cannulate the coronary arteries, but you run the risk of actually propagating the dissection flap further, and you have, you know, the risk of patient dying on the table. So nowadays, with the advent of, you know, bedside echo, X-ray, ECG, you know, CT scan, we don't really need to rush until a diagnosis has been established. I mean, aortic dissection, you have to have high index of suspicion. Establish the diagnosis first, rather than just go and do angiogram to find out your diagnosis.
Yeah, right. So in this age, with all this, you know, aids that we have, CT scans and all that, so definitely doing an angiogram is probably not the best choice in this patient, and can be detrimental, like how you had mentioned, right? Okay, so just some simple discussion on aortic dissection. So for aortic dissection, there are basically two systems of classification, the DBK and the Stanford classification, right? So we tend to use the Stanford classification. I mean, I use it just for the simple reason that it's actually easier to remember, right? You just have a Stanford type A and Stanford type B. So a Stanford type A, as you can see in this image, is any dissection involving the ascending aorta, right? So that's type A. And type B is when it involves the descending aorta, anything distal to the subclavian, right? And why is it so important for us to actually classify the aortic dissection? Because the management of the patient actually depends on this, right? So for that, I will show you another slide after this. So the most common presenting symptom of acute aortic dissection is usually chest pain, which accounts for about 79% of type A dissections and 63% of type B dissections. And the character of the pain is usually described as a sharp, tearing pain that radiates to the back, right? So, but in this patient, very atypically, he just presented with mild chest discomfort and earlobe pain, okay? And it actually carries a high mortality rate, especially in type A dissections. Okay, what are the risk factors for aortic dissection? One of it is actually long-standing arterial hypertension. Literature will tell you that about 70% of patients who present with aortic dissection actually have uncontrolled hypertension. Other risk factors include smoking, dyslipidemia, connective tissue disease, Marfan syndrome is one good example, right? We usually see quite a number of those kind of patients. Hereditary vascular diseases, bicuspid aortic valve, patients who have underlying coarctation of the aorta, and some cases of vascular inflammation, or even can be related to trauma, right? And like I mentioned earlier, why is it important for us to actually classify the type of aortic dissection into type A and type B? As I mentioned earlier, type A is actually those who would require open repair of the aorta, right? And the aim of treatment is actually to prevent aortic rupture and prevent development of pericardial effusion and cardiac tamponade. And so in patients presenting with type A aortic dissection, surgery is always indicated, right? But in patients who have type B dissection, they can be medically managed. Group of patients who present actually with uncontrolled hypertension, their blood pressure can actually be medically managed, and this can actually prevent further worsening of the aortic dissection. But in some cases, type B dissection may require endovascular repair, what we call TEVA, thoracic endovascular aortic repair. And in a small group of patients, they may also require open repair. And the aim of treatment is basically to prevent aortic rupture, right? And the indication for type B aortic dissection who requires surgery is basically persistent or recurrent chest pain, malperfusion of the distal organs, including the kidneys, the limbs, also expansion of the aortic diameter. Anything that anyone wants to add? I think we should go on to the next. Okay. All right. So this is the second Slido question, Dr. Allen. Running fast or behind? I thought you said go slow. So we will give probably 30 seconds.
30 seconds.
Okay.
Okay. Please answer. Don't forget the surprise, yeah, guys. Yeah.
So the following observations may support.
Wait, I need to.
Okay.
Yeah. Okay. Go to Slido and take the active poll is the second question now.
Q&A.
So all support diagnosis of aortic dissection except, okay, so the answer is except which one? Yeah.
Good question.
You sure people don't read properly?
Should underline the except.
Yeah. Okay, let's have at least 10 first, huh?
Okay.
Okay.
How many do we have so far?
9. Okay, 14 maybe. Okay. This one got a more clear cut, mostly sort of selected vitiligo.
All right.
So I think we will move on to. I'll leave the poll running.
All right.
Okay, and then I will switch the presentation back to Dr. Navin. Okay.
Okay. So we'll go to our third and final case. So this patient was actually a 26-year-old Indian male, pastry chef, no known medical illness, no history of asthma. He presented with a syncopal attack at home, and he was also having gradual worsening shortness of breath and diaphoresis with exertion for the past 5 days. He denied any chest pain, no history of recent travel or prolonged immobilization, no history of fever, no history of GI bleed. Okay, on examination, not pale, not cyanosed. BP was a bit on the low side, I would say, for an adult male, 100/60. Pulse rate, he was tachycardic, 130 beats per minute, regular. Afebrile, oxygen saturation was about 98% under room air. Again, slightly tachypneic with a respiratory rate of 25 breaths per minute. Trachea was central, no lymph nodes were palpable. Lungs were clear, air entry was equal. CVS, no murmurs heard. JVP was not raised. There was no pedal edema or tenderness of his calves. Right? Okay, so at this point, the possible differential diagnosis that was going through my mind at least was acute coronary syndrome. Possible, I mean, he's 28, but we are seeing our patients coming in younger and younger. Anxiety attack. Maybe his cakes didn't turn out very well that day, I don't know, right? Pulmonary embolism, another possibility. Pneumothorax. We usually describe this, in young patients, young, thin, tall patients. He did fit the description. And of course, with all the cases of COVID going around nowadays, another possibility is, was he actually having COVID? Okay, so and that's the ECG that was done on admission. We'll come back to the discussion in a while. And this was actually his chest X-ray. Okay, so first question to Dr. Kannan. Dr. Kannan, any thoughts on the possible diagnosis after seeing his ECG and chest X-ray?
I think you have gone through the differential diagnosis. I think the chest X-ray essentially is unremarkable. Definitely, there's no pneumothorax, and can't say anything more. I suppose the heart size is quite normal, so one does not have to worry about some serious cardiac pathology. I mean, one worries about things like valvular heart disease in a young person. They got acute rupture of mitral valve collapse or acute aortic regurgitation. Although there are no murmurs, if there's acute leakage of the valve, once the LVEDP goes up, the murmur might become so soft that you might not be able to hear. So the heart size being normal, I think kind of rules it out. When you look at the ECG, it's got a rightward axis, it's got right bundle branch block. There's mild ST segment elevation from leads V1 to V4 with some key wave inversion, the same leads. So when you look at it, I mean, you can certainly think about acute coronary syndrome, something like a Whelan syndrome, maybe involves the left anterior descending artery. But this is a very young person. So acute coronary syndrome, although it's a possibility, becomes rather remote. This could also go for a pseudo-Whelan syndrome that one might see in acute pulmonary embolism. I mean, it's tachycardic. Pseudo-Whelan, basically you'll find that you have biphasic T waves in V1 to or V4, V5. The R waves are essentially preserved in comparison to acute coronary syndrome. You may have mild ST segment elevation. This might be indicative of right ventricular strain if you're looking at pulmonary embolism. And I mean, you look at this, he certainly has a well-formed S1Q3 T3 appearance on the ECG, which you see more frequently in pulmonary embolism. Although it's not completely diagnostic, it's something that's supportive. So at this point in time, weighing in his age, I think pulmonary embolism seems to have come a bit more likely than acute coronary syndrome.
All right. So of course, naturally, being in emergency department, we did send a number of tests. right? So these are the blood tests that was done for him. So because thinking of acute coronary syndrome, of course, a troponin was done. It was elevated. And subsequently, because we were also thinking of a pulmonary embolism, a D-dimer was done that was elevated as well. And also a pro-BNP, a marker of heart failure, elevated as well, right? Okay, so since we have all this, okay, so Dr. Shamros, now that you've actually seen the blood test results, what is the most likely diagnosis in your mind?
When taking into account the ECG findings and then the X-ray, the D-dimer is significantly elevated. The clinical presentation would be consistent with acute pulmonary embolism. I mean, the fact that they did the pro-BNP and troponin, I mean, you don't routinely do this, but there have been studies to say that if you do pro-BNP, especially if it's elevated, it can be indicative of RV strain. The subclinical RV strain. Sometimes on echo, you can't really visualize the RV very well. So indirect assessment of the RV acute pulmonary embolism, you can actually do pro-BNP now. It's significantly elevated. It's actually an independent marker for acute adverse events and even higher mortality.
Yes,
correct, for prognostication.
And also to classify how severe the pulmonary embolism is, right? So that was the whole reason it was done, and it was actually elevated. Okay, so we've gone through these first two questions. Anything you want to add on the ECG, Dr. Shamros?
No, that's what Dr. Kanan. I mean, the most obvious thing is the sinus tachycardia.
Yeah.
It's always the first one, in pulmonary embolism. And then you can actually see the S1Q3C3 in this ECG. Yeah. And RV strain pattern, actually, like the pseudo-violent, like Dr. Kanan mentioned earlier. Yeah.
Okay, so, what bedside test you think will help with the diagnosis in this patient?
So the obvious bedside test now would be an echo, because you've got a young patient with tachycardia on the ECG, positive troponin suspicious of pulmonary embolism or acute coronary syndrome. So the echo will be looking at
I'll grab the echoes for you.
In the context of acute coronary syndrome, I'm looking for regional wall motion abnormality, like we saw in the first case that Dr. Kanan described. In the context of pulmonary embolus, we'll be looking at the right heart in particular, to look at the size of the right heart. So if you look at this echocardiogram, which you're seeing, the right heart, where you have
the right ventricle, I've labeled it,
is actually larger than the left ventricle, and in normal cases, it should be significantly smaller than the left ventricle. So this is an enlarged right heart.
Yeah.
On the one on the right, you also see that the RV is clearly bigger, much bigger, in fact, on this view than the LV, which is completely the opposite way round. So this echo actually shows right heart strain. So the pulmonary embolus is very likely in this situation.
Also, you can see that the RV is enlarged and actually compressing on the septum, what we call like a D-shaped septum, a sign of RV overload. Right, so now it's very suggestive for pulmonary embolism. Okay. Right, so sorry, that was supposed to be the next question. What would be the next step in establishing the diagnosis for this patient?
Yeah, so even without all this, I would have probably thought of doing a CT quite early on, because the CT can look at many things. Of course, here the primary goal is to exclude pulmonary embolus, so we need a CT with contrast, and then we want to describe the angiogram here.
Okay, so you actually have the pulmonary artery rising, right? And this is the main trunk, the right and left trunk. So I'll probably have to play this again to show you. There's actually this hypodense lesion that you see here, right? These are actually clots, and there's a lot of clots on both the main trunks, right, and also the segmental arteries. So it basically has bilateral pulmonary embolism. Anything to add, Dr. Yeah? I mean, it's quite obvious, right? I mean,
I think if you had small pulmonary emboli, we would not expect to see the overload on the right heart, and because the right heart is now having to work very hard, pumping against these large clots. That's why we see the right heart is very enlarged on the echo.
Yeah. So the echo findings actually correspond with the CT findings as well. Okay, so a bit of discussion on the management of pulmonary embolism. So when we actually have a patient with pulmonary embolism, we categorize them into low risk, high risk, non-massive, submassive, and massive pulmonary embolism, right? So in this patient, he basically presented with a submassive pulmonary embolism by virtue of, the CT showed a large clot burden, the echo showed a RV overload, the pro-BNP troponins were actually elevated, right? So in this kind of patients, if they're clinically well, right, in this patient, he was actually just treated with low molecular weight heparin, standard anticoagulation. But in some patients, we can actually give them systemic thrombolysis. We actually use RTPA, tissue plasminogen activator like alteplase. And in some patients, can actually undergo invasive procedures such as catheter-directed lysis or surgical embolectomy. Right, but if the patient actually presents with a massive pulmonary embolism, which is evidenced by hypotension with a systolic of less than 90, right? This kind of patients usually will require, the least would be full dose thrombolysis, right? Systemic thrombolysis. And in some patients, we can actually send them for catheter-directed lysis or also surgical embolectomy, right? So, but if patients who present with just a non-massive or low risk, they can actually just be treated with low molecular weight heparin and anticoagulation such as warfarin or one of the NOACs. Okay, so these patients, 28 years old, first venous thrombotic event, unprovoked in the sense that, there was no history of recent travel, malignancy, so, without any prior insult, he actually developed pulmonary embolism. So in this kind of patients, and in this particular patient, we actually did a thrombophilic screening. So we checked for conditions that actually, cause him to develop things like DVT, pulmonary embolism, and that includes protein C, protein S deficiency, antithrombin deficiency, factor V Leiden. And this patient was actually found to be protein C deficient in the end. And he was treated and he recovered very well. And the subsequent echoes actually showed that the RV had actually normalized, the pressures had come down. And so he responded very well. It's one of the lucky ones, right? But I've seen young patients, I had one particular patient, very obese, who presented with a massive pulmonary embolism at the age of 35. But she also had like a surgery for inguinal hernia 2 weeks before. But unfortunately, she did not make it. Okay, so we have the final Slido question. Okay, Alan, you just put up the slide, please. How are we on time?
Almost. We are good. Yeah, we're good. Okay. Okay. So this is the final poll. Please open Slido and take the answer. Again, reminder, we have a special prize for the winner. Okay.
We're waiting outside Alan's house with sticks to vacuum. You better emphasize the accept.
Accept.
I think people are not seeing the wrong
red arrow there. Is the question up yet?
Yeah, it's up. Yeah, it's showing now. You got 8 responses. Mixed, the following may increase clinical suspicion of pulmonary embolism, except, okay, except is in capital E.
I think it's changing fast.
They can change the answer.
Yeah. I think a lot of the clues were given during the discussion.
But the fastest right answer counts. Yeah, even if you change the answer, it's too late.
Nice, the answer is changing.
Yeah.
Time for questions.
Okay. I'll just see whether I can display the winner. Whatever.
You're going to see the final poll results.
No, let me see how to get the result.
Yeah, thank you. Some questions. I think question 7.
Okay, while we're going through the results, let's switch to Q&A. If you've got any questions for our panelists, please feel free to use Slido. Never mind, you can stop your presentation now, and then we go to the studio. Okay, so if you have questions in the if you have questions, you can use Slido, or if you're watching in our Facebook group or YouTube, you can respond there, please, and our panelists are happy to answer your questions. Okay.
The comments, right?
Yes, the comments are now, there are no questions so far on Slido. No questions so far. Everybody was
Crystal clear.
yes.
Well done, Navin.
It says top questions 1. No.
Let me
Last comment is nice case, right?
No recent questions either.
I think everyone's eager to know the winners.
The winner, I haven't figured out how to show the winner yet.
Why wasn't troponin done in case 1? Yeah, right. I mean, this case was done. I mean, this case was about 4 or 5 years back, right? And I can't remember exactly if a troponin was done at that point in time, but the cardiac enzymes were quite elevated, and based on the clinical presentation, I was there by then and did the echo quickly, so I didn't think that the troponin was actually relevant at that point in time. But yes, you're right. I mean, that would have actually helped to clinch the diagnosis much earlier, but like I said, the patient did not present with a typical presentation of ACS, so I think that's why it wasn't done. Is that the answer?
No other questions?
I can't see.
So sorry, I don't know.
Yeah.
Not right. Yeah. No other questions so far. Yeah. The question. Yeah. No question was thank you.
No, I think that's the same person saying thank you for the answers.
No other comments. Yeah. Maybe I'll just comment on the pulmonary embolism.
Can interesting.
Yeah. I think I agree with the management flow. I mean the diagnostic as well as yeah. I mean, I think it's what would you have chosen if this patient had was a little bit hemodynamically compromised?
Hemodynamically compromised.
Maybe a bit low. Which would be your choice? I just want to know.
Well, I mean, in that kind of, I mean, in a place like this where we have catheter-directed lysis, we can probably get that done, more directed therapy. Systemic thrombolysis, I think, is also an option. It can be used. I have used it before in patients who have actually presented with hypotension, and they actually made a very good recovery. Yeah, and in this case, alteplase.
So I think the answer depends on the facilities available.
Yeah.
Because systemic is easy to give, but it carries a higher risk of bleeding. Again, we've seen people with bruising all over their face after systemic thrombolysis. Whereas catheter-directed needs the facility, the skill, and it takes a bit of time to organize. So if you can organize it very quickly, and you've got the person doing and do it for you, or if you can't do it yourself, then I think that's preferable. But it depends on the facilities. Yeah.
So since we're on the subject, like, if you have patients who actually test to have one of these thrombophilic conditions, long-term treatment, warfarin versus the newer group of anticoagulants, what would be your choice?
Okay, I think the question arises is how long to give, and what to give for. Here you have unprovoked pulmonary embolism, and not only unprovoked, you have actually identified an underlying thrombophilic. So usually, such young people, unfortunately, will probably end up having lifelong anticoagulation. Choice between ordinary warfarin or one of the DOACs would be depending on the individual. I think you look at the whole picture because there's cost to it. There's whether the patient can come for repeat testing, how compliant they are, and you have to balance the risks of somebody who, especially in our local population, they will take all sorts of drugs, herbs, and all that. There's always a risk of over with drug interaction. Whereas DOACs also, there's the issue of they still need to come for monitoring, and they still need to monitor the kidney function. It's not that you can give them the drug and go off. The other problem I find that there's no way to know whether they are definitely compliant because we don't test.
There's no way of monitoring it.
We don't test it. Those tests are not routinely available. And bleeding generally will be less. But if they do bleed, apart from the newer ones, there's no available antidote. And then, but usually it's safe enough because the half-life is quite short, so you stop. So you have to balance that as well. I think it's a discussion, a conversation you have to have the patient. You don't. There's no straightforward answer. Is warfarin better or what? Because you're talking about really long-term anticoagulation in this young individual. Yeah. So it's a conversation you have to have with the patient, and then you decide finally. But there are pros and cons.
Thanks, Alan. So I think we have
somebody asked in Facebook. COVID-related problems. Everything is COVID these days.
Okay.
Yeah.
Asking as in this patient?
I don't know what the question is.
Question. I think it's a general question.
Oh, this patient was COVID negative, by the way.
Okay, so this was not COVID-related problems. So I think that's the question. I think we can. There's one question in the Slido. Case number 1, if in a clinic setting, if the BP picked up after fluid hydration, serial ECG is normal, null cardiac enzymes available, should you still refer to hospital? I think so.
Well, that depends on how comfortable you are just sending the patient back. Yeah. If you think it's just purely gastroenteritis from the history, the patient had significant volume loss, and if the BP picked up after fluid hydration, ECG was normal, then probably in those kind of cases, you can probably, send the patient back, right? But if you are thinking of something more and you feel like, you're not confident that, maybe some tests need to be done and you don't have it in your setting, then it's best to refer the patient to the hospital.
I would probably be very careful. If someone presents hypotension, they need to be observed at least for 24 to 48 hours. They might go home, the BP might drop again for whatever reason. So I think just a clinic visit intoxication is...
Yeah, so I don't think so you can actually generalize this. Yeah. It depends on your assessment of the patient.
I think that anybody who comes anywhere to my clinic, to a hospital with hypotension, I'd be very uncomfortable to send them home straight away. At least 24 hours of observation.
Will it be negligent if I miss ACS since the ECG was normal?
Can I ask a question?
Yeah.
To a normal non-cardiologist, if the patient presents with diarrhea, a bit of hypotension, I run in fluids, and then ECG looks normal to me, I would think it's just gastroenteritis, and they respond.
Right. Yeah.
And if I'm not mistaken, I'm not a cardiologist, but I remember vaguely from my MO days, in RV, in fact, they respond to fluid challenge too, don't they?
That's right.
Isn't it? So we could miss this. ACS.
So that's why we keep emphasizing on the fact that the patient was not tachycardic, did not actually point towards volume depletion. So.
Yeah, but even if it's inferior infarct, even if you do give volume, initially they might pick up.
Yeah.
But later on, if you have an ongoing infarct you haven't established the flow, it will manifest.
So that's all, I would say, probably temporary things that we do to stabilize the patient before we actually give the definitive treatment. So eventually, I think if the myocardial function is deteriorating, the amount of fluids that you give is probably irrelevant.
There's one question. How accurate are the on-site CHOP-T tests, and is it useful in GP clinics? I think you meant GP clinics.
Any
I can't answer that. Anybody else can answer it better.
How accurate? Well, I don't know. I guess there are a lot of kids out there.
I don't know
We
how
use it.
expensive is it? I mean, to do it in a GP
We do
setting.
have the point of care test that we do, even our emergency setting, and it's fairly accurate. So,
Yes, if you have the money,
yeah,
but don't delay the referral to the hospital.
Correct.
I mean,
Just because, yeah, you
ACS
don't have it.
testing, you know. Yeah.
The important thing to remember also is that there's a window period that if you do it soon after the symptoms, I think now it has come down to about 3 hours. The test might be negative in someone with an acute condition. You must remember.
So it's not just one test, it's the whole clinical.
because I think we've also discussed this in the previous grand rounds. We had patients who came in too early, usually less than 6 hours, and probably the troponin could have been negative at that point in time.
How much time do we have?
We have exceeded already 8 minutes. So, Mr. Chairman, you want to carry on or you want to close? We will show the QR code.
Okay, I think, are we showing the results of the...
Yeah, I'm struggling to find out how to show. I think I'll have to go through the analytics and then we can't display the, I'm afraid, we can't display the winner now. Let me see. Anyway, I think we will
just go to my last final slide, just closing slide.
Okay, right.
Okay, so, Avia? Okay, so, yeah. So basically the conclusion of today's grand rounds is you can learn a thing or two from Deepak Chopra, right? So don't think out of the box, just get rid of the box. Most patients do present with typical symptoms, but in medicine, nothing is definitive. So always have a high index of suspicion. Good clinical skills and basic bedside tests may help to clinch the diagnosis in patients who present with atypical symptoms. So thank you. That's the end of our session today. Stay safe and get vaccinated.
All right. We will now go on to the
Conclusion part.
Okay. Don't forget, you cannot scan with the same device. You need another device to scan the QR code. So I'm going to display the code now. Okay. If you're watching this video later, the code will be active for about an hour. So you have about an hour to scan it. Yeah. With the MMA app. Oh, okay. All good? Anybody managed to scan? Yeah. Work for you, yeah? Okay. I'll leave it on for a while, and you should be able to rewind in case, or fast forward to this point in case you are watching this one later. Okay, you don't, even if it disappears from the screen as we stop the broadcast. Okay, if you have any problem scanning the code, if you are registered for the event, please contact Kellen, okay, who had emailed you the links, and she will help you with the CED points, okay? I'm afraid we can't help everybody, so it's only those who actually registered for the event. Let me see one more time if I can get the analytics. For the winner. I have to dive deeper. I don't know. Okay. I hope I can find a winner. I'm so sorry.
All right. So we'll notify the winners later then.
Yes. Okay.
Thank you very much.
All right. Thank you all for watching. Thanks to the panel and Navin. Great moderation and presentation. Great cases. I enjoyed it. Yeah.
Thank you.
Okay.
Have a good weekend, everyone.
Bye-bye.